Derita, derita, derita. Stop, stop, stop. Okay, okay. Up, 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 up. Don't move. Asparagus.
Hey guys, what's up? It's Stephanie and welcome back to my channel. So I'm going to do an updated version. I had already previously posted a video about what was my hardest rotation so far, but I had not completed all of my rotations. Now I have completed all of my rotations. And so this is just an update. In that video, it was definitely my ER rotation, just because of the preceptor I had. But in this video, I will be discussing so I've completed all of my rotations, I already graduated from PA school, and what was my most difficult rotation. So my most difficult rotation was definitely my burn rotation. I did burn, I had my burn rotation. This was kind of like an elective rotation. I did this as my capstone rotation. Not all PA programs have capstones. My program is one of the ones that do. Basically what a capstone is that you finish your clinical year, and after your clinical year you kind of get like a semester where you complete a rotation in whatever you want. I did mine in burn, and the reason why I did it in burn is because I'm from Texas, San Antonio, and before applying to PA school and getting accepted into PA school, I worked in a variety of hospitals throughout the city of San Antonio, and most of the patients that came in that had like really severe skin problems, whether it was burns or like SJS or TENS, back then I didn't know what that was, we would transfer them to our burn center. And I was always fascinated by the burn center, and so I always wanted to do my rotation there. So when I found out that my program was affiliated with the burn center, I was like, I'm doing my rotation there. And I did. And I'm very glad that I did, because I learned so much. And I have to say, by far, it was the most difficult rotation I had done. But I learned so much, and I'm very grateful that I did. And that's one of the reasons why I did it also, because I knew it was going to be a hard rotation. You're dealing with patients that are very ill. They're acutely critically ill. They come in with like a large percentage of their body not having skin. Patients that have SJS or TEN. It's really intense, and I'm very interested in emergency medicine and critical care medicine, hospital medicine, so that's why I decided to do this rotation, and I loved it. There was definitely a huge learning curve for me, and I can say not only for me, but I know for all the other medical students that were there also, and some of the residents that had to rotate there. It was all a huge learning curve for us, but it was definitely worth it. So why was the rotation so hard? Like I said, because it was such a high learning curve. And another thing I have to say is that during PA school, like during my didactic year, we only learned about burns in one day. So out of the entire didactic year, we only had one day for burns. And here I'm doing a rotation where the specialty is burns. So of course, not everything that I was taught during my didactic year in that one single day was what we did in the burn unit when I did my rotation there. We did a lot more. I learned about a lot more creams, solutions. You know, in PA school, you're kind of taught, I think now they're including also you're taught about first, second, third, fourth degree, right? But usually in the burn unit where I'm at, it's superficial. You have partial thickness, deep partial thickness, and then your full thickness burns. So it's completely different terminology. And then of course, you know, how do you diagnose these? You read in textbook, but it's different once you go and see these patients. How do you calculate the percentage? So Lumbrowder wasn't one of the ones that we used when we were diagnosing and just calculating the TBSA in a patient. And it's a lot more different than doing it on a question that asks you, you know, the patient has 9%, the patient has like half of their torso or their full torso or their full back burn, versus you actually seeing a patient. Because you see a patient, their burns are mixed, so it's full thickness, partial thickness, deep partial thickness, etc. It's not only always one burn, it's mixed. And so that was something I also learned. Not only that, not only in the burn unit are you managing patients with burns, but most of these patients have a lot of comorbidities. We had a lot of patients that were diabetics that came in because some of them, their diabetic neuropathy is just so bad that sometimes they just place their foot. I had one patient that was at a bonfire and they didn't even realize their foot was on fire. So we had patients like that where we had to manage their comorbidities, like their diabetes, acute renal failure, chronic renal failure. We had patients that come in that had COVID, so not only were we managing the COVID portion, but we were also managing the burn. We had patients that came in with, not only did we see burn patients, we saw Stevens-Johnson syndrome. That's a whole different treatment plan. I had one patient that passed away from Stevens-Johnson syndrome. Well, she has Stevens-Johnson syndrome /TENS. Toxic epidermolysis, pemphigus vulgaris. You also had gangrene, right? So many other different comorbidities that I saw. I saw Guillain-Barre syndrome. I only read that in textbooks, and I saw that finally on a patient that was an IV drug user. She came in because she developed neck fash to her forearm area, and she had gangrene to that area, so she ended up needing to have surgical debridement. And then also from surgical debridement, she developed, after that, Guillain-Barre syndrome, so she was paralyzed from the neck down. So how do you treat these patients? She was developing sacral ulcers because, of course, she's not moving. She's only one position. We're having to switch positions. And how do we treat the sacral ulcer? How do we get the Guillain-Barre syndrome under control? Giving her immunoglobulin, etc. So not only was a burn part of it, but also, every other part of it, managing the comorbidities, managing their diabetes, having to, observe these patients. Do they need to go to surgery or not? You make that decision depending on where the burn is located. Is it circumferential, right? If it's circumferential and if it's like a deep partial thickness, it can compromise blood flow. So these patients need to go to surgery. Your electrical burns, what type of burns is it? Is it a thermal burn, electrical burns? Electrical burns are scary because they cook the skin and your muscles from the inside out. So most of these patients have to have emergent fasciotomies. And not only that, you're managing the consequences, especially we got a lot of electricians that would come in for electrical injuries. We had a patient that had a subdural hematoma. He had vertigo also. So you're managing all the other comorbidities. Your patients are diabetics. You're checking their sugars every day. Do you need to change them from a high dose sliding scale insulin to a medium dose sliding scale insulin? Are they not responding to the high dose sliding scale insulin? What else do you want to add? Do you need to consult internal medicine to treat the patient's hypertension to see if they have any recommendations after you've used more than 3 medications to treat their hypertension? Do you need to consult infectious diseases in regards to the best treatment for a patient that has Bacteroides fragilis, etc.? So, that's why this rotation was difficult, but I learned a lot. I learned how to properly give a presentation, not a sloppy presentation, how to give and the appropriate information that you need to give in these patients. So how to also give handoff. So at the end of the day, I would give handoff to the residents, and you needed to make sure you go through all the patients that you had and give them just the pertinent information, not go through, well, the patient had X amount of mLs today. The patient had, just anything that is, they need to know. So the patient go into cardiac arrest today? If they did, what did you do for them? Did you order cardiac enzymes and they're pending to see what their, what the results are? Did you do a culture, any chest x-ray, etc.? So, giving the appropriate information when you're handing off these patients to your residents or to the individuals who's going to be taking care of them. So that's why it was such a huge learning curve for me, and just burn management in general. When are these patients going to go to surgery? If they are, what type of surgery do you recommend for them? I also really like that I was able to scrub into surgeries. Burn surgery is completely different to all the other surgeries that I've seen. And yeah, this was definitely by far my most difficult rotation. I felt in comparison to day one where I knew nothing, in comparison to the last week, I did progress, improve, but definitely I did not know everything about burn medicine because it's just so complex. And like I said, we're managing the comorbidities of these patients, and not only burn, you're having to have knowledge of everything. And so this was definitely a huge learning curve for me. Fantastic rotation. I really recommend it for those of you who want to do critical care medicine, emergency medicine, like I said, or hospital medicine. If there's a burn unit in your state or around you and your program is affiliated, then definitely take advantage of it because it's a huge learning experience that you get, and the fact that also they're very helpful and they really wanted you to learn. Burn surgeries, the PAs I rotated with, was another good thing about this rotation. So during this rotation, like, I acted like as if I was a solo PA, already practicing PA, which makes sense, right? Because it's my last rotation, it's my capstone rotation. So I also learned how to make notes, how to appropriately make notes that are succinct, but they're not saying over to information that's not relative, but they are including the appropriate information. How to give, also how to present a patient, right? Present them according to body systems, so cardiovascular, pulmonary, etc., going down and not being all over the place, which I did all the time when I started my rotation. Like, I would start with, oh yeah, the patient has a urine output of X, and then I would go into, the patient's blood pressure is this, and then I would go back into, oh, and the wound's like that. Like, I was all over the place. So of course I was losing the individuals that were trying to follow me, because we did rounds at 7:30 and we rounded on every single patient. You had a burn surgeon, you had the nurses, physical, occupational therapists, you had psychiatry also, since most of these patients have like PTSD or generalized anxiety because of their burn trauma. And so they're following with you with the patient on what you're saying, and if you're all over the place, you're going to lose them. So it's really important that you go in order and you're presenting these patients and presenting the appropriate information. So that's why definitely this one was one of my hardest rotations, but I learned a lot. Highly recommend it. Blessed to have completed the rotation and to have learned so much, and I hope to use this information in the future. So yes, this was my rotation. Loved it, loved it, loved it. Highly recommended. Alright guys, as always, hopefully this video was helpful for you guys. If you guys have any questions or anything like that, feel free to comment below, or you can send me a message on Instagram and I'll try to respond as soon as I can, okay? Alright guys, I'll talk to you guys later. Bye.